Hey, good afternoon, everyone. We are here again for another chat community conversations. And today, well, again, I always forget to introduce myself. My name is Craig, and I am the vice president or first vice president of the Jamaican American Connection. And I have the special opportunity to introduce our ladies today. First, I will introduce our facilitator, Deborah Moxham. She is the co-founder of ISOE Commercial Capital, LLC. She is the vice president of business and commercial financing. So, a little bit about Deborah. She's an entrepreneur, community leader, and she's passionate about helping others succeed. Uh, She's a Brooklyn native and Skidmore University graduate. She was shaped by her Jamaican parents' values of hard work and entrepreneurship, gaining early people skills and business experience in her family's dry cleaning business. She has moderated or participated in various topics from budgeting to home ownership to starting a business and health matters. Her love for people and commitment to making a difference is the core of everything she does, both personally and professionally. And I will now introduce Dr. Tanisha Grant. She's our expert that we're going to, is going to share some information today. Dr. Grant is a board certified gastroenterologist who practices in New Haven, Connecticut. She has been in practice for 13 years and treats adults with a wide range of intestinal conditions, ranging from acid reflux to constipation, and is a strong advocate for colorectal cancer prevention. So, again, to our guests, thank you for joining us this afternoon. I hope you guys like and subscribe to our channel. Share this meeting right now with your friends and family so they could join in. So, Debbie, I turn this over to you.
Thank you, Craig, and thank everyone for being on our podcast today. Today, we are diving into a critical health topic where we are discussing colorectal cancer, particularly how it impacts kidney health and overall wellness. Joining us today is Tanisha Grant, a renowned nephrologist who is here to help us understand this connection and what we can do to stay informed and be proactive. Dr. Grant, thank you very much for being here today. Can you share a bit about your background and what led you to specialize in nephrology?
Thank you, Debbie. And thank you for agreeing to host. It's such a pleasure to see you virtually.
Thank you so much.
So just a few points of clarification. So I am all about the colon and the digestive tract. And I actually specialized in gastroenterology because I was really fascinated by digestion, as obvious as that seems. But the GI tract actually starts in the mouth and ends in the anus. And there are organs from the intestines, the stomach, the pancreas, the liver, the gallbladder. And each of those organs can actually be affected by different diseases. And when I was in medical school, I thought, this is so fascinating. And because there was so many different organs involved, I thought this would be a subspecialty that would be very exciting and challenging to learn about. And I thought I would be constantly challenged and never bored because there's so much incredible variety. And I have to say, after practicing all these years, that has held true because I've never gotten bored. Gastroenterology is also considered to be a procedural specialty, procedures by way of endoscopy. So, whereas surgeons are able to operate and make incisions on the skin in order to get to the organs, I do procedures, and so there's no cutting. all of my endoscopic procedures are done internally. So I'm able to treat ulcers and polyps and different abnormalities within the lumen of the GI tract, as we call it, but there are no cuts on the skin. And so with an endoscopic procedure, one of the advantages is that it's incisionless, but I have some of the job satisfaction that one would get from being a surgeon in that I perform procedures, which is very satisfying. The endoscopic procedures require a lot of dexterity. And so my sister and I grew up playing video games. And so we were always really challenged by the video game controllers and having to navigate those obstacle courses to get to the targets and to get the prizes. And I have found unintentionally that those, dexterity skills that I gained from video game has actually really served me well in my current profession. I also took some piano lessons when I was growing up. And again, that dexterity has actually helped to really sharpen my endoscopic skills. So I chose gastroenterology for all of those things. The wide variety of pathophysiology that I see within this subspecialty. And also I really enjoy it because it's procedural. And so I get to practice my dexterity related skills. So it's been very satisfying.
Thank you very much for correcting me, because I did do a FERPA and a FLUPS, and I said nephrology. So yes, you are a gastroenterologist.
Yeah.
We've had so many discussions in the past with regards to kidneys and how they relate with the gastroenterology and the colonoscopies that everyone probably on this podcast has already experienced or will be experiencing in the upcoming years. So my apologies. Thank you for clarifying that.
Oh, you're welcome. So we have a doctor within our organization, Dr. Mason, who is a nephrologist. So she's the kidney expert. I cannot take credit for that, unfortunately, but we'll have her on one of these days to talk all things kidney.
Wonderful. So let's get back to colorectal cancer and what we need to pay attention to.
Yes. All right. So I thought I would do today's presentation by first sharing a few slides. And we'll go through approximately 16 or so slides, and then we're going to open it up to the audience and take questions. And then we'll have a live Q&A. So for the audience members, please feel free to leave all your messages and questions in the chat. And we will get to each of those questions at the end of the slide presentation. So we'll get started. I'm just going to share my screen with you. So I'll pull this up in just a second. All right. Are you able to see my screen?
Yes.
Okay. Oops. All right.
Looking good.
Okay, good. All right. Okay. So today's topic is going to be about the basics of colorectal cancer. And colorectal cancer screening is one of the main parts of the job of a gastroenterologist, because the bulk of our job includes colonoscopies and screening for colonoscopy. Screening for colon cancer. And colonoscopy, as I will discuss later on, is the gold standard for colorectal cancer screening. So the subtitle of today's talk is The Unhealthy Gut. And some might argue that a cancer diagnosis is really the ultimate in, having an unhealthy condition develop. So let's start by reviewing the anatomy of the digestive tract. So on the left of my screen, you'll see the digestive tract as a whole. As I mentioned before, the digestive tract really starts in the mouth and ends at the anus, which is the very last part of the digestive tract. But within that area, as I mentioned before, you have multiple different organs, including the liver, the gallbladder, and the pancreas. So the intestines or bowels of the digestive tract are actually broken down into two main categories. The first category, which is the area after the stomach, is known as the small intestine. And then from there, we go on to the large intestines, also known as the colon. And so in the image on the right of my screen, you'll see that the colon is then further broken down into the ascending, transverse, descending, sigmoid, and rectum. And so you might sometimes hear us refer to colorectal. So the colon part of that term refers to the parts of the colon excluding the rectum. So that includes the ascending, transverse, descending, and sigmoid. And then the rectum is the last 6 inches of the colon, which is the very last part of the colon. And then following the rectum is the anal sphincter or the anal canal. So again, I just thought this brief review of the anatomy would be helpful because sometimes the nomenclature can be a little bit confusing, and sometimes the terms are interchangeable in terms of colon and large intestine. So today we're going to talk about cancers that affect the last part of the digestive tract, which is the colon and rectum. So also of late, we always talk about a healthy digestive tract or GI tract versus an unhealthy digestive tract or gut. And so sometimes these discussions about gut health can be kind of steeped with some stigma, if you will. Digestive health and problems affecting digestion can almost be viewed as being undignified. I was once watching an episode of a television series, and one of the characters was affected by colorectal cancer. And he actually said, "Oh my goodness, I almost wish that I had gotten a more dignified form of cancer." And I think a lot of that stems with, the digestions and the guts not being associated with things that are necessarily dignified or conversation worthy. Definitely not conversations that you have in, polite society or proper spaces. So sometimes there's some shyness and some embarrassment related to discussions related to gut health. And I think even the term gut in and of itself sometimes carries a negative connotation, So we're going to try to change the connotations related to the word gut. I was a little bit inspired and uplifted because with social media, we've been seeing lots of more positive commentary related to the gut. And I did a quick search this morning on Instagram in particular, and searches for things like hashtag gut health, hashtag gut health matters, hashtag gut health 101, hashtag gut health program. All of those are trending. And as you can see, those trends are as popular as 11.8 thousand posts to as many as 6.5 million posts. So I think, again, this is one of the benefits of social media, that we're, beginning to dispel some of the negative connotations, related to gut health and trying to make this a more acceptable conversation to have. Unfortunately, when the gut becomes unhealthy, one of the manifestations and one of the scariest manifestations of an unhealthy gut is colorectal cancer. So as many in our audience might remember, these two celebrities are two of the more famous ones who were affected by colorectal cancer in the past several years. So on the left of my screen, I don't need to tell anyone who this person is. This is Chadwick Boseman, who passed away from colorectal cancer at the tender age of age 43. And then on the right of the screen is actress Kirstie Alley, who was a star in the television sitcom commercial Cheers, which my sister and I were great fans of and grew up watching that show. And Kirstie Alley, unfortunately, died from colorectal cancer at the age of 71. So with, whenever celebrities are affected by one of these cancers, as unfortunate as it is, one of the advantages is that it really increases awareness and gets the public attention. And by increased awareness, there's more research and, all eyes are turned towards colorectal cancer, hopefully for more of a prolonged period, more so than a brief period. But just to mention a few of these celebrities. So let's talk a little bit about the epidemiology of colorectal cancer and what the disease burden is really like. So colorectal cancer is the third most common type of cancer in the United States and is the second leading cause of cancer-related death in the United States. There is a lifetime gender-based risk of 1 in 23 men and 1 in 25 women. So that's, not insignificant at all. So definitely something to keep in mind. And this will tie into the importance of screening, which I'll get to later on. So there is recent data that shows that early onset colorectal cancer is something that we definitely need to pay attention to. And these statistics show that by 2030, cases of colorectal cancer in people less than 50 are expected to nearly double. The death rate from colorectal cancer for 20 to 54-year-olds rose between 2004 to 2014. Before then, the death rate had been going down uniformly. However, with those recent statistics, the death rate from colorectal cancer has been increasing, but I must specify that it's increasing in young people, again defined as people less than age 50. But the overall rates of colorectal cancer have continued to decline by about 2% annually. So the overall rates have declined, which is reassuring, but very concerning that the rates of colorectal cancer in the young are unfortunately on the rise. So most people under age 50 with colorectal cancer don't even have a family history. And so this I'll get to a little bit further on in my talk. We have this question of what is driving this increase, and we don't exactly know exactly what it is. So those born in approximately 1990, so those approximately age 30, versus those born in the 1950s, those approximately age 70 or so. In those younger 30-something-year-olds, they have a 2 times higher risk of getting colon cancer and a 4 times higher risk of getting rectal cancer. So again, you can see that the incidence of rectal cancer in particular has been on the increase in the younger people, which is kind of skewing the overall data. So this led to the US Preventive Services Task Force to actually change the recommendation from screening people starting at age 50 to beginning screening at age 45. And I'm sure many of our audience members know that 45 is the new 50, which we like to see in GI. That's the new buzzword that we should all start getting screened at 45 and not 50. There are also some risks of colorectal cancer related to age. And in particular, I wanted to focus on the higher risk of colorectal cancer in African Americans and people of African descent. So Black people have one of the highest rates of colorectal cancer of any racial ethnic group in the United States. Again, these are staggering statistics. So 24%, their incidence of colorectal cancer in African American men, which is what the AA on my screen stands for, is 24%, while the incidence of colorectal cancer in African American women is 19%. And these rates are relative to their white counterparts. So again, 24% increase in African American men and 19% increase in African American women versus their white counterparts. Also, the mortality rates are much more staggering for African Americans compared to whites. So an African American man is 47% more likely to die from colorectal cancer than his white counterpart, and an African American woman is 34% more likely to die from colorectal cancer compared to her white counterpart.
Dr. Grant,
And yes.
that is very interesting, and I know you'll probably touch upon the disparity and why our African American men are more likely to be diagnosed with colorectal cancer as compared to our white counterparts.
I know, and we don't have a lot of data, unfortunately, but the overall consensus seems to focus on the lack of access to high quality screening in the African American population. So the thought is that somehow they don't have access to invasive and non-invasive screening options, because as I'll get to later on, there are screening options besides colonoscopies, but for some reason, these patients are not being informed of what their screening options are. And also, when they are diagnosed with colorectal cancer, there has been studies that shows that they are lost to follow-up and that the post-diagnosis care is also suboptimal. And so that has all contributed to these statistics. There's also some data that shows that physicians are sometimes not discussing screening, age-appropriate screening during doctor's visits, or perhaps the physicians are reserving those conversations for another visit. So, for example, if a patient comes in for a non-physical related exam, then they might not necessarily, get the conversation that they should start their screening. And so now there has been quite a push for all the healthcare providers to take the opportunity to discuss the, screening during any visit and just take an opportunity to mention that screening is needed, regardless of the reason why the appointment was scheduled.
Thank you.
Electronic medical records also have different alerts that are automated. So the alerts are automated in terms of screening based on age. So, for example, if I am a 40-year-old woman and I go in to the doctor because my elbow is hurting, the provider will see an alert on the screen that, oh, she's 40 and it's time for her mammogram. So the provider is automatically alerted that even though the visit might not necessarily be related to breast health, that a mammogram is indicated. Likewise, if I'm 45 and I go in for an earache, the provider will be prompted that, oh, it's time for her to have her colonoscopy. So different system-wide practices have been implemented in hopes of trying to kind of nudge the primary provider, the medical providers, that they need to order the screening. So we're trying to make some headway. There have also been different initiatives. The Colorectal Cancer Alliance has been making different initiatives to try to increase awareness in minority populations to kind of get the word out about the importance of colorectal cancer screening. There's a television host on the Today Show, Craig Melvin, whose brother died from colorectal cancer. He is also a great advocate in terms of reminding viewers to get their screening colonoscopies because he lost his brother. He hosts a golf tournament to raise funds to go towards colorectal cancer research. So again, I really commend these celebrities and these TV personalities who use their platforms to try to spread the word, but we're making some inroads. We're not quite there yet. And hopefully, one day we'll really be able to implement these changes so that we can really kind of, even out these numbers so that the discrepancies are not as stark as they are. But some of the things that I just mentioned are some of the reasons why there's such a discrepancy. I know it is very, alarming.
Thank you.
And, I say all of this to say because Africa has one of the lowest rates of colorectal cancer in the world. And so we know that these differences are not genetic. We know that these differences do not have a biological basis. We are not just genetically more prone to getting colorectal cancer. The discrepancies probably stem more from disparities within healthcare and screening not being recommended. So again, this is also another good place to kind of segue into always reminding ourselves that we need to be our own best advocate, right? And also one of the reasons why these conversations are so important, right? To be educated and informed that even if you go to see your provider and there's no mention of the necessary screening, right? By having these conversations, we will know, and we will also educate our family members and our peers about the screening tests that are age appropriate. So because we are the one constant and we are the ones who are seeing a multitude of providers, we have to advocate for ourselves in order to get our screening. And
Yes.
that's always recommended. So other risks besides younger age and race include diet and lifestyle, which is where some of the more gut health focused conversations kind of come into play. So as with any other health condition, unhealthy living also increases the risk of colorectal cancer. And things that can contribute to an unhealthy lifestyle include a sedentary lifestyle, tobacco use, excessive alcohol, family history of colorectal cancer is not something that we have not in our control, so that's non-modifiable. A personal history of colonic polyps and or previous cancer, a personal history of inflammatory bowel disease, and those include Crohn's disease and ulcerative colitis. Also, a history of intra-abdominal radiation is thought to increase the risk of colorectal cancer, as well as a history of kidney transplant, just to kind of tie into our earlier talking point. So persons who have had renal transplants are actually more susceptible to getting colorectal cancer. So that is a risk as well, just to kind of tie those two organ systems together. So let's talk a little bit about why diet and lifestyle is so impactful on the gut. And one of the reasons why this happens is that the gut is actually an incredible organ. I'm a little bit biased as a gastroenterologist, not that all the organs aren't fantastic, but because this is my area of focus, I am always in awe of the gut, that the lining of the gut actually replaces itself every 5 to 7 days. Every 5 to 7 days, there's a cycle of sloughing and repair and replacement of the lining of the gut, all as a way of kind of housekeeping, getting rid of the useless cells, the debris, the toxins, the damaging cells. All of those things are sloughed from the colonic lining and replaced with healthy cells every 5 to 7 days, which I think is remarkable. You know, the liver also has the ability to repair and regenerate itself whenever it is significantly damaged, but the colon also deserves some credit for being able to do that as well.
That's amazing.
However, however, no system is perfect. And unfortunately, at some points during this repair and replacement cycle in the colon, mistakes can happen. And when those mistakes happen, one of the consequences is that we can develop abnormal growths or clusters of cells from the lining of the colon known as polyps. And colorectal cancer can develop from polyps. And so these polyps grow from the lining of the colon and the rectum and can then progress to becoming colorectal cancer if not removed early. So this is a progression from colon polyp to cancer. So you'll see on the extreme left of my screen that these cellular abnormalities start at hyperproliferation, then they go on to become adenomatous polyps, which are precancerous changes. They start out as being very small, and then they can progress to becoming very large. And then as the genetic abnormalities and the cellular defects continue to progress, these polyps can develop to becoming severe dysplasia, also within the precancerous categorization. And if these polyps are not removed while they're precancerous, they then become adenocarcinoma, which is the most common type of colorectal cancer. And then that can progress further, even to becoming invasive cancer, which is where the cancer actually invades through the lining of the colon.
And
After it invades, yes.
question, Dr. Grant, generally in your experience, what have you seen as the advancement? Does this occur over a period of a month, a period of a year, or 10 years?
Very good question. So I'll just take a step back to say that not all polyps are precancerous. There are some polyps which are known as hyperplastic polyps, which are completely benign polyps. And then this other large category of polyps are called adenomas or sessile serrated polyps, which are the precancerous types. Because these cellular changes and defects are happening so slowly, the progression from polyp to cancer can take as long as 10 years, if the progression even happens at all, because only about 5% of the adenomas or the precancerous polyps even become cancer. So not all precancerous polyps will progress to becoming cancerous. Only 5% of them do. So the ones that do continue along that, pathway from polyp to cancer, that progression can happen as slowly as 10 years.
Thank you.
Which again kind of emphasizes the importance of screening. Because again, if we're able to examine the lining of the colon and remove these potentially precancerous polyps before they progress, that's why screening is so important. And that's why screening can be preventive, right? So colorectal cancer can be prevented by screening.
Thank you.
And I'll get to that a little bit later as well, but that was a very good question. But this progression from polyp to cancer is a very slow one. And maybe that's a good thing because it buys us some time and it
Yeah.
can take as long as 10 years.
Excellent.
So oftentimes I get asked the question, how would I even know when I have a polyp? And oftentimes polyps cause absolutely no symptoms. And it doesn't matter if they are completely benign, like the hyperplastic polyps I mentioned before, or if they are the precancerous types. Neither of those two typically cause symptoms. Later on, as those polyps become larger, they can sometimes cause bleeding. And if they become very large, then they can sometimes obstruct or block the lumen, the inside of the colon. As opposed to colorectal cancer, which interestingly enough also doesn't cause symptoms in the early stages. So when a colon cancer is quite small, it is unlikely to cause symptoms. And the symptomatology related to a colorectal cancer also depends on the tumor location. So if you remember the anatomical figure I showed at the beginning of my talk, where the colon is divided into ascending, transverse, descending, sigmoid, and rectum, if the polyp or if the large polyp or colon cancer is on the right side of the colon, meaning the ascending colon, then a polyp in that location is unlikely to cause symptoms unless it's very advanced. As opposed to a cancer that's on the left side of the colon, meaning a descending or sigmoid colon located tumor, because those parts of the colon are a little bit more narrow than the rest of the colon, cancers in those areas are more likely to be obstructive and impede the passage of stool. So if there's a cancer on the left side of the colon, as we call it, symptoms can include, sometimes you'll hear pencil thin stools, smaller volume stools, constipation, diarrhea. Sometimes the cancer can actually become what's called a fungating mass, which is exactly how it sounds. It starts to look like a fungating mass that can sometimes become ulcerated and bleed. So one of the other symptoms is that blood from the bottom can sometimes be a sign of a colorectal cancer. Sometimes the bleeding has been going on for an extended period before it actually becomes visible to the naked eye. And sometimes with that chronic blood loss, persons can become anemic or even iron deficient, because remember that the red blood cells carry iron. And so if you're losing red blood cells from a mass that's bleeding, the blood count will decrease and the iron levels will also decrease. One of the symptoms of iron deficiency anemia is fatigue. So unexplained fatigue, abdominal cramping, bleeding, change in the stool caliber, changes in bowels, constipation or diarrhea, bloating, unexplained weight loss. All of those can be symptoms of colorectal cancer. And as I said before, and I really want to emphasize this point, unfortunately, sometimes those symptoms don't develop until the cancer is very advanced. Again, just to emphasize the importance of screening and also to emphasize the importance of not ignoring symptoms. So whenever there is a new or alarming symptom, it's really important to seek medical attention and not ignore it and hope that it will go away. Always better to go to see your primary care provider and let them reassure you rather than, staying home and assuming things will resolve and that things will improve with time, because unfortunately, oftentimes they don't.
That is so true. My aunt, our old time Jamaicans, where we handle everything with our bush tea, right? And my aunt she experienced all of the symptoms that you have up on the screen. And by the time she went to the doctor, because she says she's going to have her bush tea, she went out and get her little bush and she boil it and she take it. And by the time, Dr. Grant, she went to the doctor, she lived for 8 weeks.
Oh no.
So
I'm
yes,
I'm very sorry to hear that.
yeah, personal, yes, when you say you have to be screened and do not wait, it is very true because we have it firsthand experience in our family. Yes,
Oh, that sounds devastating.
yes.
I am hoping, I hope that, her situation would have been the outlier where the little bush tea really was the cure. But I'm sorry for your loss.
Yeah, so it's as you said, as you bring it up, we have to be screened. We have to share this conversation, and we can't let our old time and our fear of doctors keep us away from
Yeah.
acknowledging what's going on. And if it's not normal for us to have, sometimes everyone has diarrhea, sometimes we have constipation. But what would you say if it goes on for how much longer? What is your rule of thumb?
I would say 2 weeks. If the diarrhea or the constipation or the thinner stool or the smaller volume stool, if any of those things persist for longer than 2 weeks, I would seek medical attention.
Definitely.
And the bleeding, I would actually go right away. The bleeding, I would go right away. Even if it's hemorrhoidal bleeding, you have no way of knowing if it's only a hemorrhoid. And I'm saying only a hemorrhoid because a hemorrhoid versus a colorectal cancer, when you're comparing those two, a hemorrhoid, as painful as it can be, is, not an ominous diagnosis. And so sometimes bleeding is related to something as benign as a hemorrhoid, but sometimes even I'm not able to say with certainty in the office if it's just hemorrhoidal bleeding and something that we can treat with a topical steroid and sitz baths and fiber, for example, or whether or not this bleeding is something that needs to be investigated endoscopically. So bleeding, I would go to the doctor immediately. Sharp, sharp, crampy abdominal pain, I would go to the doctor right away. Diarrhea or constipation that seems to be lasting for longer than 2 weeks, I think I would go at that time.
Excellent.
Because as you said, sometimes we can have changes in our stool habits based on what we're eating, based on medication, based on stress levels. All of those can affect the frequency and the consistency of our stools. So those things can take a while before they really involve, depending on what else is happening in your life. But the bleeding, that is what we call an alarm symptom. It's a red flag, you know. So an alarm symptom or a red flag, as we like to say in medicine, unintentional weight loss. And again, this is not weight loss of just a few pounds, right? This is a significant amount of weight because everybody's weight fluctuates by a few pounds, even on a day-to-day basis. So if it's just a mild day-to-day fluctuation in weight of a few pounds, that probably doesn't require urgent evaluation. But if you've lost 10 pounds in a month without dietary or medication or exercise changes, then that should prompt you to seek medical attention. Yeah.
Thank you.
You are welcome. So again, as I mentioned, 45 is the new 50. So as you also mentioned before, Debbie, everybody who has a colon should be screened. So everyone should be screened beginning at age 45. And again, I must specify here that someone at average risk is the person who should start getting screened at age 45. And average risk is defined as someone who only has age as their risk factor. So we all age. And so, as I mentioned before, once we get to age 45, if that is the only risk factor, meaning that there is no family history, there's no history of Crohn's disease, ulcerative colitis, intra-abdominal radiation, polyposis syndromes that run in the family, such as Lynch or familial adenomatous polyposis syndrome. If you don't have any of those risk factors, then you're considered to be average risk. And so you should start getting screened at age 45. And we usually continue screening until about age 75. The population has been living longer. So age of mortality, life expectancy has increased over the years. And so not every 75-year-old is as healthy as the next. So we always individualize the recommendation about exactly when to stop performing screening colonoscopies. But I would say on average, we stop at about age 75. And the rationale for when to stop is that we always have to weigh the risks of screening versus the benefits of screening. And as I mentioned earlier, as you brought up, Debbie, the progression from polyp to cancer is a very slow one. So even if you develop a new polyp at age 75, it will take about 10 years before that polyp becomes a cancer. So potentially you might not really have a colorectal cancer that, related to that precancerous polyp that started developing at age 75. And at 85, you are more likely, persons are more likely to succumb to other medical problems. And so colorectal cancer becomes a little bit less of a pressing concern. Again, depending on the overall health of the person. And so it's always a very individualized discussion between the person and their primary care provider. What are their goals of care? Do they want to accept the risk related to screening, or would they prefer to defer additional screening based on age and goals of care discussions? So there are several different types of screening options available. This is a little bit of a busy slide, but basically it talks about invasive options for screening, which are colonoscopy and sigmoidoscopy, versus non-invasive options, including a CT colonography, which is a CT colonoscopy. It's a virtual colonoscopy, or stool-based tests, which are the FOBT, FIT test, and the MTS DNA test, also known as Cologuard. So I don't know if you guys remember that President Barack Obama actually had a CT colonography because I think he didn't want to have the anesthesia to have the procedure. He was the president of the United States at the time. And so there were some security reasons related to him, having anesthesia for a traditional colonoscopy. And so he opted to have a virtual colonoscopy, which is a CT colonography instead. So for the colonoscopy, again, it's an endoscopic examination of the entire colon. It has the highest sensitivity for colorectal cancer detection, meaning that it is able to detect greater than 95% of the precancerous lesions, and definitely 95% of colorectal cancers. If the colonoscopy is normal and the person undergoing the procedure is considered to be at average risk, then their next colonoscopy should be performed in 10 years. So oftentimes patients will ask me, what about non-invasive testing? I don't really want to have this colonoscopy thing I keep hearing about. I don't want to drink that awful tasting laxative. I don't want anyone looking at my butt.
Yes.
So what are my options besides having this colonoscopy? Nothing against you, Dr. Grant, but is there something I can do in the privacy of my own home? So a colonoscopy is a one-step screening test. You do your procedure and that's probably the only test you'll need for screening for the next 10 years. And then the non-invasive or the stool-based tests are called two-step screening options. And they are called that because if either any of these three tests I have listed are abnormal, meaning that they are positive, then the recommendation would then be to have a colonoscopy. So if you have a negative test, then it's a one-step test. But if you have a positive test, then it then becomes a two-step screening option process. So the first one is a FIT test or fecal immunohistochemical test, which detects the presence of abnormal DNA and or blood in the stools. And if it is negative, then it's repeated every year. But if it's positive, then we then have to go on to doing a colonoscopy. The Cologuard is the microsatellite testing DNA, and it is the more sensitive than the FIT testing. And it is basically looking for abnormal DNA in the stool. And if it's negative, that test can be repeated every 3 years, and that can be done for colorectal cancer screening in lieu of a colonoscopy. The most recent test is the Shield. It was FDA approved in 2024. And this one is actually a blood test. And this is a test that detects tumor DNA in the blood. We don't really have clear guidelines yet as to what the Shield testing frequency should be if there's a negative test result, because this is the newest test that we have available. And I think we need some more data before we can actually give recommendations about how frequently this test should be performed if it's negative. So colonoscopy is the gold standard for screening and also for polyp and colorectal cancer detection. Colonoscopies are actually the most commonly performed outpatient procedure in the United States. Colonoscopies are not only performed by gastroenterologists like me, but they're also performed by colorectal surgeons. And so having other providers from other specialties perform colonoscopies will hopefully help to improve access to care, right? So if there's just a few gastroenterologists doing these procedures in your area and you don't have, the waiting period is months to years before you can get in, then it's also nice to have the option of having your colonoscopy performed by a colorectal surgeon. So as I mentioned before, the colonoscopy is considered one-step screening. We are able to examine the entire length of the colon from the ascending colon on the right all the way to the anal verge, which is the lowest part of the colon on the left side. The colonoscopy is the gold standard because it is both diagnostic, meaning that we can find those precancerous polyps and we can take them out all in one procedure. And if it's a negative test and it's a high quality exam, meaning it's done by a skilled, experienced provider, then it offers long-term protection. Again, you don't have to have another colonoscopy for 10 years if your initial test is negative. So let's talk a little bit about ways of reducing our risk in terms of things that can be modified. So diet, as with everything in medicine, a healthy diet and lifestyle bodes well for overall health. So the data has specifically shown that minimization of red meat intake, especially processed and cured meats, are thought to reduce the risk of colorectal cancer. So processed meats are things like salami, prosciutto, right? All of those are processed meats. I love them too. I love a charcuterie board, but I was a little upset to find out that this is not so healthy for my gut, not such a good thing for gut health. So minimization of red meats in particular, avoidance of processed foods is also thought to reduce the risk of colon cancer. Increasing dietary intake has thought to be beneficial. And I think this is because fiber is a prebiotic, right? This is a whole separate conversation that we can have But remember again that prebiotics nourish the bacteria that are in our gut. The colon has trillions of bacteria. We all have these commensal organisms, as they call them. We live in symbiosis. There's a fine balance between the good bacteria and the deleterious bacteria. Fiber nourishes the bacteria in our colon and help us to digest. Fiber also promotes regular bowel movements, and so it's important to eliminate waste from the colon. So a high fiber diet helps to optimize bowel movements and bowel regularity. All of those things are associated with a lower colorectal cancer risk. Exercise, as we all know, is critically important. So aerobic exercise, cardiovascular health is important, gut health is important, and all very promoted by an active lifestyle and getting aerobic exercise regularly. And regularly, we usually say 30 minutes at least 5 days per week. But even like a 15 to 20-minute walk, a brisk walk around the neighborhood will, go a long way as well. So our previous Surgeon General, Vivek Murthy, actually advocated for alcohol being labeled as a carcinogen. And so again, these are things that we all know, but alcohol, especially alcohol in excess, is carcinogenic. And so limiting alcohol can also promote a healthy gut and decrease the risk of colorectal cancer. Smoking, we all know the dangers of smoking. Smoking is associated with a higher risk of all types of cancers throughout the body. So we all know the importance of avoiding tobacco. And the last two are ones that I actually added. These are not a part of the widely accepted recommendations, but stress, which can be so pervasive, leads to chronically elevated cortisol levels. We're always in fight or flight. The body is just always revved up. That's not a natural state to be in, and it can lead to cellular damage and genetic abnormalities over time. And so again, exercise can actually help to mitigate stress. Sleep can help to mitigate stress. So a lot of these things have a lot of interplay and are related. So again, healthy living is best to minimize the risk of colorectal cancer. So again, we spoke about this a little bit, Debbie, in terms of how we can really impact these staggering statistics for African Americans and people of African descent. So as I mentioned, there are some modeling studies that show that, again, it's not a genetic reason why the rates of colorectal cancer is higher in African Americans than whites, because they found that in whites and African Americans or Black people who had age-appropriate colorectal cancer screening with the same frequency, their colorectal cancer risk was the same. So it's again not a biological reason. It's not a biological reason why this discrepancy exists. It's really mostly thought to be related to inadequate access to care. And so we are trying to come up with, beneficial screening programs. As I said, the celebrities who are diagnosed or the television personalities who have their platforms, they have the megaphones and they're helping to increase awareness. Platforms like the Jamaican American Connection and our conversation here today is also helping to spread awareness. So we're making some strides in terms of minimizing these risks, but we have a long way to go.
Excellent.
So a few takeaways. Again, just want to emphasize that we should all know our personal risk. And we have spoken about this in our previous conversations that sometimes we really don't know our family history. Sometimes our parents or grandparents didn't have access to screening. You know, I am from Portland, Jamaica. My grandmother was from a very rural part of Jamaica. We never knew anything about colonoscopies. We didn't know anything about the little Cologuard. We didn't know anything about stool-based testing. So family history isn't always known, because we don't have the conversations. But sometimes family history is not known because the testing wasn't available many, many, many years ago, you know? So I think we'll just need to give each other a little bit of grace. But, again, we're hoping that these conversations that we're having today will inspire additional conversations within families. And so we can really, share our medical histories with our loved ones so that they know what their risk is, so that they can then advocate for themselves with their medical providers to say, hey, I had a relative who had colorectal cancer. Should I start getting my colonoscopies at 25? Right? Never a bad conversation to have. So again, I'm a gastroenterologist. I know the value of getting a colonoscopy, but I understand that there are really some persons who cannot have a colonoscopy because they don't have transportation or they don't tolerate the prep or, whatever the reason is. We don't really force anyone to choose colonoscopy. We always say that the best screening test is the one that you will choose, even if it's a stool-based test. Screening is covered by insurance. Again, I want to emphasize that it's important not to ignore symptoms. Your doctor or medical provider will not dismiss you for something that you think is trivial. The bush tea, naga fix your colon cancer, right?
Yes.
Colorectal cancer is preventable. 70 to 90% can be prevented through screening. And colorectal cancer has a high cure rate if detected early. And let's continue to promote hashtag gut health. So a few things to end. March is Colorectal Cancer Awareness Month. So you might have seen the blue ribbons all around. And today is actually National Physicians Day. So I wanted to really commend my fellow physicians who are part of the Jamaican American Connection and those watching a happy National Physicians Day. Thank you for all you do. And also to give a little bit of a shout out to my alma mater. I attended Titchfield High School in Jamaica, and my sister was a few years ahead of me at Titchfield as well. So that's us pictured outside Titchfield, June of last year when we visited for the first time after about 10, 15 years. So it was a pleasure to go back and kind of visit some of our roots and kind of, say thank you. We didn't see the teachers, unfortunately, but kind of go back and pay homage to the place where it's, started in so many ways, the place where it really started and where we really got that really strong educational foundation. So, and that's it. So from here, that's the end of my talk.
Dr. Grant, that was very informative. We covered a lot in the last 45 minutes. We have simply a couple questions that has come in through the chat. So
Okay.
without further ado, and March is also Women's Month. So we have to, commend the women that we have that are our guests today, and also impart the importance of self-care and ensuring as women, we're always taking care of our family and our mother, brother, cousin, spouse, children, but we have to make sure we take time for ourselves. Wouldn't you agree?
Absolutely.
Okay, the first question is, how does gut health influence other systems in the body, such as the immune system or mental health?
So the gut is actually within the gut, we actually have a lot of immune cells. So the GI tract is actually a part of the immune system. So, for example, um, if there is an infection, sometimes an infection like a diarrheal infection, for example, sometimes after having a diarrheal infection, the gut barrier can become so disrupted that the toxins from the gut can actually permeate through the in between the cells of the colon and get into the bloodstream and affect the body as a whole and really disrupt immune function. And so one of the things that has been proven is that if there is some disruption in the normal balance between the good and the good and the bad bacteria in the colon, by way of damaging the gut microbiome, then with disruptions in the gut microbiome, that can then go on to cause immune system dysregulation. There is strong data to support the negative impacts on the gut microbiome as it pertains to autoimmune diseases, for example. So, with autoimmune diseases, the body starts to attack itself, and some of the root causes have actually been traced back to disruptions in the gut barrier. In terms of mental health, so I think from a very simplistic or a very basic level, if bowel movements are irregular, that can sometimes cause a negative effect on mood. Um, there are lots of, and I'm not trivializing this by any means, but there are lots of like cartoons that talk about, the benefits of having like a satisfactory bowel movement, for example. And sometimes with severe constipation and or even severe diarrhea that's persistent, it's really frustrating, it's really upsetting, it really affects quality of life. I have patients who are not able to carry on their day-to-day activities because they have significant diarrhea and or constipation. And that has a negative impact on mental health. It can start out as being frustration, but any chronic medical condition can cause major depression. So anything that goes untreated for a significant amount of time can be a risk factor for major depression. So any chronic illness, be it a GI-related illness or other, can negatively impact mental health.
Thank you. You sort of touched upon the next question that we have is how often should you have a normal bowel movement?
I will say one more thing about the previous question, which was pertaining to the impact of gut health on mental health. So within gastroenterology, there is irritable bowel syndrome or IBS. And IBS is considered a functional disorder, meaning that there is no organic or anatomical basis for the disorder. And the main symptoms are abdominal pain associated with change in stool frequency and or consistency. So it's usually abdominal pain with constipation or abdominal pain with diarrhea. And sometimes those symptoms can cause a lot of anxiety, right? Again, anxiety related to leaving the house, anxiety related to possibly having an accident or becoming incontinent of stools. And, with IBS in particular, we're not sure if it's the IBS that then leads to anxiety or if it's the anxiety that then leads to the IBS. There's the gut-brain axis. And so we're not sure which one came first. And so they're probably negatively feeding into each other and becoming they tend to perpetuate.
Yeah.
So with this question about stool frequency, we always say that the goal is at least 4 bowel movements per week.
Okay.
But again, everyone is different. But I would say on average, if you're able to have about 4 bowel movements per week, then I think that should be adequate. But again, please keep in mind that stool frequency will depend on your hydration status, how much fiber you're getting, what medication you're taking. There are medications that can cause constipation as a side effect. It depends on how much exercise you're getting. So all of those things will impact the frequency of the bowel movements. One thing to really ensure is to make sure that your bowel movements are complete, because even if you're having a bowel movement every day, it is possible that they are incomplete. You're having very small stools. You feel as if there's still a lot of stool left behind, even though you've gone. So you could technically have a bowel movement every day, but if it's not a satisfactory, complete bowel movement, then it's inadequate. And that's also not ideal. So I would say about 4 complete bowel movements per week.
So 4. Okay, so that's good. We are at about an hour, but we have several questions. So I know we value everyone's time. So if you can hang in there just a couple more minutes, because we have 3 other questions that we would like to get to. The next question is, what are some of the things that can possibly go wrong when doing a colonoscopy procedure in terms of what to look for before, during, or after? What would just if you can speak to that briefly.
Good question. So possible complications are the most worrisome complication is perforation, which is where the lining of the colon can become torn during the colonoscopy. And that can happen as a result of the colonoscope actually tearing the lining of the colon. Or it can also happen if we remove a polyp and the resection goes through the lining of the colon. There are possible complications: infection, bleeding, perforation, aspiration, which is where fluid from the stomach goes into the lungs in patients who are under sedation. But the most dreaded complication is really a perforation. Sometimes the endoscopist can detect the perforation during the procedure and clip the defect closed before completing the procedure. If it's a larger perforation that is discovered after the procedure, then that might require surgery. Symptoms of a perforation are severe abdominal pain, cramping, bloating, fevers, or chills after the colonoscopy. And those symptoms usually develop within about 24 to 48 hours after the procedure.
Now, mentioning this, we do not want to scare our audience, because we want to ensure that they understand a colonoscopy far outweighs the dangers of what can happen, but it can enlighten us to any diseases that is existing and that is festering in the colon. So while we do have every procedure, every surgery has their side effects that the doctors always spend a time with. Um, However, the percentage of this occurring, what would you say, Dr. Grant?
So it's about 1 in 2 to 3,000 patients. It's a very low risk.
Very low.
But
Yes.
again, as you said, the risk of the colonoscopy outweighs the benefits. And the risk of any endoscopic or surgical procedure goes down based on the experience of the performing provider. So the more experienced and the more skilled the person doing the procedure, the less likely there is to be a complication.
I've had my colonoscopy and I came out no problem. So we do not want to scare any of our guests on today. The
Right.
next question is it possible to request a colonoscopy before the 10-year mark if you suspect abnormalities?
So I am going to assume that this question means that there are symptoms. So I would say if you're having symptoms that are concerning, it definitely should be discussed with your medical provider, and then they will have the discussion with you about whether or not the colonoscopy would be a reasonable next step.
Thank you. Is it true that being extremely constipated can impact your body odor or breath? That's an interesting question.
That is an interesting question. I don't think so. Um, There is a condition called small intestinal bacterial overgrowth, or SIBO, which can sometimes present as constipation. And there is some data that says that there is a little bit of like an odor on the breath in patients who have SIBO. But some of this is all anecdotal, meaning that we don't really have scientific studies that really confirm. These are just patient reports. And then patients who say once the bacterial overgrowth has been treated, then their symptoms resolve. In terms of body odor, that is not one that I am aware of. Um, I'm not aware of body odor and constipation in particular. No.
Thank you for addressing that. The last question we have is, how does intermittent fasting or meal timing affect gut health?
So I think it is important. I don't know. I think it's important that we spoke about when I had our first guest speaker, Dr. Chang and I, she spoke about sleep. And we spoke a little bit about the two arms of the nervous system, the sympathetic and the parasympathetic. The sympathetic is fight or flight, and the parasympathetic is rest and digest. So the rest and digest part of the nervous system is really where the body has a chance to relax. It's supposed to literally rest and digest, where systems are downregulated in order for metabolism to be optimized. And so with fasting, the data recommends fasting for at least 12 hours per day, just to allow the body to digest the food that's already within the system so that we're not having to expend that much more energy breaking down the food that continues to be consumed. So I don't think that it has to necessarily be intermittent fasting as the goal. But I do think the recommendations of allowing for digestion to be optimized within at least 12 hours. So, for example, last meal is at 8 p.m. and then breakfast is at 8 a.m. During those 12 hours, the body really has some time to digest the food that has already been ingested.
Excellent, thank you. We had one other, with regards to, again, we're touching upon Women's History Month. We're discussing a health issue that affects both men and women, but it often gets overlooked, which is colorectal cancer. As we celebrate the women's contributions, we also want to empower women and men with knowledge that can save lives. This was a very informative hour, and we could speak on this topic for the next several hours. But again, we at JAC, the Jamaican American Connection, we value everyone's time. We thank you very much for joining us for this very, very serious topic. As we discussed earlier, the shame, the disparity, even if we touch upon prostate cancer for men don't want to be touched down there. Mm-hmm. So it is avoided. And then we have men who, by the time they find out about prostate cancer, it's too late, it has spread. So again, we want to impress the importance of screening, as Dr. Grant shared earlier, the importance of listening to your body, the symptoms that go unanswered or unheeded. And again, if you're experiencing any symptoms, please seek medical care. Do not talk to your buddy about it. Do not talk to your girlfriend. Talk to a medical professional. If one doctor, brushes it off, seek another doctor, because we have to be in charge of our medical situation. Each situation is very different. Wouldn't you agree, Dr. Grant?
Absolutely.
If you speak to 5 different individuals, they may have all the same symptoms, but all of the symptoms can speak to something else. So it's very important to seek professional help. And if one person doesn't listen, please continue and do not let your symptoms go unheeded. That's it for this episode of JAC Conversations. We thank each and every one of you for joining us. We would ask that you continue to like and share our videos. Invite your friends and family to subscribe to our channel at JAC, Jamaican American Connection, on YouTube. And without further ado, Dr. Grant, again, forgive me for my faux pas earlier when you are not a nephrologist, you are indeed a renowned gastroenterologist.
Thank
So
you
with
so
that,
much.
we thank you so very much and we wish everyone a great evening. Craig?
One second. Just wanted to also mention we have some additional conversations on the channel. Our first one of the year was about sleep hygiene with Dr. Chang. Our second one was with Dr. Camelia Lawrence, who's also a JAC member, all about breast cancer and knowing your risk. And then our third one was about mental health, which was hosted by Delise and our very famous guest. Now she's renowned,
Yes.
Juliet Bosley, aka Julie Mango. I also gave a talk last year about diet and nutrition that was hosted by Kanisha. So please go and check out our previous conversations. And I know we've kept you too long, so I'm going to turn it over to Craig. Thank you.
Thank you,
Thank
Dr. Grant. Thanks, Craig. Take it over.
No problem. Thank you, ladies. Again, thank you, Dr. Grant. Thank you, Deborah, for facilitating. Definitely an informative session. So, as Deborah mentioned before, please like and continue to share this channel with your friends and family, and please subscribe. Thank you again for joining with us. Please be on the lookout for more conversations coming up this year, even this month. All right. Happy Sunday, everyone. And again, thank you.
Thank you.